Viera, Duke Majin. We're here at Duke Spine Institute, and we are going to be performing a Duke laser disc repair on a patient who has, can you scroll? Spinal stenosis, narrowing of the spine in the neck due to what are called disc osteophytes, which is herniated disc with bone spur. And our patient doesn't want an open fusion, which is the alternative. So they've requested the Duke laser disc repair as their choice procedure, which does not involve any fusion or open surgery. The purpose of our surgery is to remove as much disc osteophyte at 2 discs that are pushing on the spinal cord. And we need the patient fully relaxed, which they may be.
I just gave additional, and blood pressure is 88/40.
Yeah, I need it up just a little bit so I can feel the carotid.
I think with your incision, I'm hoping.
Well, we don't do the incision just yet.
Okay, I will bring it up.
Just a little bit.
No
Yeah.
problem.
So to do the Duke laser disc repair on the neck, we have to go in the front of the spine, and I have to go between the carotid sheath and the esophagus and trachea. Shot. So 2, 3, 4, 5, 6. We need to be further south. And we've prepped out both sides of the neck because with this particular patient, with his anatomy, we may have to switch sides depending on the results. Shot. All right. So 2, 3, 4, 5, 6. You agree?
I agree, sir.
All right. I agree too. Now, I'm going to try to go just a little bit lower. But as far as relaxation, he's nice and relaxed. I like it.
Thank you, doctor.
I'm happy about that. Thank you for doing that.
Okay, June. Please,
Shot.
step up, please.
Okay. And I'm going to need an AP
You can lift it up.
now. I don't know what you're doing. You're getting me an AP. Come on. Hurry up, Jordan. That looks good. Go back to a lateral. Shot. Shot. AP. Coker. You're too close here, Jordan. Come on. You're still too close to the patient. Why is that? Get this thing higher up. Shot. I need a better AP. I need the spine in the middle, the spinous processes. That looks better. All right. Well, let's see. Shot. That looks good. Lateral. Oh, we're pretty much in the middle, slightly off to the patient's left, which is the side that I'm working on. Take this. So I'm really happy with our position. Shot. Are you pulsing? Good. Shot. So we're into the disc at C5-6 at this point. Shot. And the next step is a discogram. And his disc spaces are pretty collapsed. Let's just make sure he's nice and relaxed and stays that way. I actually feel like he's relaxed. Shot.
Blood pressure is coming up, 90/60.
That's fine. You don't need to bring it up anymore.
Okay.
So I needed it just in the beginning, and now I'm happy with where we are.
Okay.
So you can keep it, in the 90s to 80s, whatever you want to do.
Okay.
Shot. Okay, so we're injecting some dye, and this is going to stain the herniated disc or the degenerated disc. 2, 3, 4, 5, 6. So we have this one and the one below. Now this patient has problems at many discs in the neck, but they're not all causing pressure on the spinal cord and nerves. These two are the worst. These two are the ones that I felt needed to be fixed surgically because they were causing what's called stenosis. Stenosis is Latin for narrowing. They were causing stenosis or narrowing where the nerves are. All right, let's get a Coker and give me an AP. Coker, AP. So right now we're doing something called navigation, where we're navigating our way down to where the herniations are. And it's a process. And the way we do this is we use an X-ray machine. It's perfect. You can see the dye leaking out the foramen on the left. You can see the nerve root being outlined by the dye. So definitely in the right place. I'm very happy with this. Let's go back to a lateral. So from an anterior posterior or AP view, we're in perfect position. On a lateral view, we need to go further backwards towards the back of the disc, but I can do that with the dilator. I'm not too concerned about it. I just got to make sure the patient is relaxed. Shot. So you can see there's a lot of arthritis in the back of that disc. We're not going to be able to get all of it out, but we're going to get as much out as we can and then buy this patient some time before the disease ultimately and eventually will cause more narrowing, but that usually is a process that takes years and years to occur. So the alternative for this patient would be a fusion procedure, an anterior cervical decompression infusion or a posterior cervical decompression infusion. We have epi in the injection.
Yes, sir.
We're injecting local. 3 cc's, or actually 2 cc's injected. All right, that's where we are right now. That looks good. Let's just wait for a minute. Originally, I was going to go on the right side, but the patient has a little swollen area, and it's benign. They've had it biopsied. They're going to have it removed by their ear, nose, and throat doctor, but I didn't want to take any chances and go on that side of getting into that thing or having that affect our surgery. So I went to the opposite side that doesn't have any issues, and that's why we're doing the surgery on the left. Of course, I got his permission to do that. It's called informed consent, and we did that for sure in the pre-op. I've made a 4mm incision in the skin. Now I'm going to bring this is called a dilator, and dilators are used in minimally invasive spine surgery. How's our blood pressure?
90, so over 59, I'm working on it.
All right, that's fine.
Gently.
Yeah, I appreciate it. Let's just not let it climb up. 96 is fine, but I don't want it to go any higher.
Yes, sir.
So I'm passing between the vital structures of the neck. Shot. And this is the hardest part, in my opinion, of the entire surgery, is getting this navigation and what's typically called in surgery the exposure, getting that done safely. Exposure means we're exposing so that we can treat. With surgery, we're exposing the part of the body that needs to be operated on or treated. Shot. In this case, we're starting with the 2, 3, 4, 5, 6 disc. Everybody in agreement?
I agree, sir.
All right, so 2, 3, 4, 5, 6. So we've got the C5-6 disc. We've accessed through the front. We're now passing through the disc, and we're going to get to the back of it where the problem is. The problem is not the front of the disc. The problem is the back of the disc. Shot. I was able to advance the dilator a little bit into the disc. And he's fully relaxed, right?
Fully relaxed.
All right, let's get one more AP real quick. We're about halfway, maybe almost halfway. I want to make sure that I'm embedded within the disc safely before I go any further. So you need what's called biplanar fluoro. That's perfect. Yeah. All right, let's go ahead and go back to a lateral view. Biplanar fluoro means two. Bi is two. Planar means planes, two planes. Two planes of fluoro, meaning that we're using at least two planes. It's truly multiplanar fluoro, meaning that we're using multiple planes. Now when I do this, I kind of let the dilator find its way, and I don't rush it. I take my time, because what you want done is, you can see the disc space has spread apart, okay? And by spreading apart, it's only able to do that because the patient's relaxed. This is one of the big differences between what I do and what the Koreans, who originally taught me the surgery, what they do. Sean? They have the patient awake. And when the patient's awake and you're doing this to an awake patient, it hurts like hell for the patient, and they're squirming around on the table, and their muscles are contracting because they can't be relaxed because they're awake. You can only relax a patient's muscles when they're asleep with general endotracheal anesthesia. Otherwise, you're going to lose their airway, and they're going to die of suffocation. So it's a basic principle of anesthesia. The only way you can relax a patient's muscles, their skeletal muscles, with medication during surgery is if they're under general anesthesia, they're intubated and the airway is secure. So the Koreans don't do that, and I think that's part of the reason why they've had complications with their surgeries, that we have not had any complications with the Duke laser disc repair in the United States. I'm the only surgeon in the United States and North and South America that does this surgery and shot. And I always put my patients to sleep under general anesthesia. Look how nicely I'm able to advance the tubular retractor, you know, and the only way this is possible is through distraction of the disc space. Shot? Basically separating the bones from each other, slowly and gradually dilating, we call it in surgery, which means to widen, to open a hole or path, and you can see the tubular retractors going in, albeit slowly. Shot? I'm just taking my time. Shot? I want to make sure that the dilator, the little thing sticking out at the end, that doesn't go in any further. It can probably go in another 5 millimeters safely, but I don't want it going any more. And the reason for that is if it goes in much further, it can actually touch the spinal cord, and we don't want that. So we want just to bring it in close to the spinal cord, but not quite there. Shot? Shot? So I saw a really good movie last weekend. For those of you who like movies still. Is that me right there? And that movie is called Parasite.
Oh, I heard about it.
It's a Korean movie, South Korean. And it's really good. Really good.
It's about human parasites?
No, it's actually, I thought it was about like zombie movie, but it's not. Because Koreans love zombie movies. I can't say what it's about because it's very original, very different than anything I've watched in a long time. And
Okay, well, there's subtitles.
subtitled.
Can you speak Korean?
I cannot. I speak a little bit because my wife is South Korean, but I mostly know the food, so I can order food at restaurants. And some of the bad words, so I can cuss at my wife and children in Korean and not get people looking at me funny in public. Right?
Did you meet her in Korea?
I did not meet her in Korea, no. I met her in the university in Gainesville.
No kidding.
Yeah, she was working in the neurology department, working with the epileptologist. I need something cushiony.
Dr. Roper?
No, Dr. Roper was an epilepsy surgeon. She was working with an epilepsy neurologist.
Messing with you.
What was his name? Dr. Sean? Oh my gosh, I can't remember his name. It's horrible.
Still there?
I don't know if he's still there.
Neurologist is epileptologist.
Yeah, he's a neurologist that does epilepsy. I think we're good right there. That's about as good as I can get. It's not Oken. Oken does movement disorders.
Yeah, my husband works with them.
No, it's another guy. All right. This is going to be fun. Trying to separate these two. Shot? Huh? That's it? All right, so let's see what we can do to extract this guy. This is where Augusto's strong hands always came in.
Thank you very much.
Let me see. I'm just kind of figuring it out. I need a wet cloth. Go ahead and use some of the local.
90 over 54.
Yeah, we're good. The blood pressure is good. I'm happy with it. I'm just have these two.
Once you're already in there, I can raise it up a little bit, or
How much higher do you want to go?
like 95.
Yeah, yeah,
Thank you.
no problem.
I already
I mean, I'm in there right now, but I'm trying to get this dilator out of the
kind
tube.
stuck, you know.
Yeah, so
I gave him some Decadron, very
is
tiny.
you did?
Dexamethasone.
The only worry I have is pulling it all the way out, which would suck. Shot? Uh-huh. All right, why don't you try to lever that and I'll hold the tube in. Yeah, oh, beautiful job. Luis, that's teamwork. I love it. High five, good job. Okay, let's take a look where we are. That's it, perfect. Now you look how much we open up the disc space. A lot compared to what it was before. So, you know, we get challenges sometimes in the operating room. You can see little things happen, little deviations, which surgeons don't like deviations. We like everything to be the same every time, consistent. As long as, if you're a good surgeon, that's what you like, because you figured out the right way to do it to get the best result, and you want that same way every time. Okay? And I don't like surprises. So I like it just to go exactly perfect every time the same way. But of course in life you don't have that opportunity all the time. Even in surgery you don't have that, because everyone's body is a little bit different and they present different challenges. So, but we overcame that one. I'm very, very happy about it. We're going to bring the endoscope in and we're going to go down and take a look. So I expect this patient to have more bone spurs than we normally would see. And there's a piece of herniation right there. So we're going to start by removing that. Then I'm going to get us in focus. Now go ahead and turn the light back on and pull the fluoro back just slightly. Now can you see this tool that I have?
Yes, we can.
So this is called a pituitary rongeur. It's a standard neurosurgical instrument, and it has a little grabbing mouth at the end. You all see that? Okay. But it's really long and German made, and I use it to go down and grab out pieces of the herniation that are loose. The laser is very good at freeing up the fragments of herniation that are stuck down, scarred in, so to speak. They're scarred to the annulus. So it's truly an annular debridement that I do with the laser primarily, and then the grabbers are the one is how we get the chunks out. Now most of the chunks come out by just floating out with the fluid that we have running in here, and that fluid kind of moves things out, which is nice. But sometimes you get a big old chunk and it won't just move out on its own. So you have to grab it. So let's get the light up a little bit, light intensity. Yeah, one more maybe. That's good. Maybe it's too much. Let's go back. We're at 20. All right. So unfortunately the bone spurs here. This is the herniation, by the way, the blue thing. And the bone spurs are so substantial that they're causing a flickering. But you can see there's no movement of this disc. It's horrible. This patient's bones are just like, they're like super glued together basically by the inflammation from the annular tear and the herniation. So what we find is a lot of the patients that have the Duke laser disc repair, they actually get better movement. There's absolutely no movement right now, but by the end of this surgery, you're going to see better movement of these bones. I'm actually trying to move them right now, and I can't move the bones at all. So that's because they're like, this patient's herniation has just stuck them together. So we're going to work on this, getting it out. We're a few millimeters away from the spinal cord, so we have to be careful. I can already see a little bit of movement, which is good. You can see the herniation there I'm working on. Woo! This irrigation is cold. It's good, but it's cold on my fingers. I need mittens. Yeah, sterile mittens. The reason the irrigation is cold is because the laser is hot. The laser beam is hot. It generates heat. So to prevent it from damaging any of the tissues like the nerves or spinal cord that I'm working around, I need the liquid that it's bathed in to be cold. So it counteracts the thermal, gradient. Okay, everything's going good so far. These are the herniations that we're pushing on a spinal cord. That's down there. So we're going to keep working slowly, albeit. This would be a really good time to ask questions if you have some.
We do have a couple.
Sure.
We have one question that was submitted through our app. The viewer asks, can a person be healed of numbness in both legs and feet with terrible balance and tightness at the knee joints due to a slipped disc in the lower back?
Whew, that was a loaded one. All right, give it to me again.
So it sounds like this viewer has numbness in both of their legs and feet and terrible balance problems with tightness in the knee joints due to a slipped disc in the lower back. Can this all be healed?
Can that all be healed? Yes, it should. The tightness in the knee joints, I would want to examine the knees to make sure you don't have arthritis in your knees, because you may have arthritis in your knees which won't get better fixing your lower back. So if you have arthritis in your knees causing stiff knees, then you need something done on your knees. So that would be just a physical exam and maybe some diagnostic tests like an MRI or X-ray. But yes, a slipped disc in the back, a herniated disc, which is the same thing as a slipped disc, that herniated disc could definitely cause symptoms in the legs that you're describing. Even pain around past the knees, there's a piece of herniation. But I would just need to do an exam. So if you have a herniated disc and you're having leg symptoms going down your legs like that, then yes, the disc herniation is probably the cause. All right, how are we doing on our scopes? Did the company repair them?
Yeah.
And how do they look?
I mean, this is one of those.
Uh-huh.
So if you don't like it, I resend it back.
Well, the problem is every time I bend it, the image blurs. You see that? So there's a herniation. See that? So that whatever glue they used is not holding the fibers rigid.
Okay, I can talk to them today. Okay.
Yeah. So look, right now it's
Yeah.
it's reasonable,
Yeah.
and then when I push it this way, it blurs. When I push it this way, it blurs.
Got it.
So,
Yeah, I talked to them today.
yeah, I mean, a little bit of pushing
Yeah.
should not cause the image to blur. The fibers should be glued better,
Yeah.
but they're moving with a little bit. Now, this may be the new the technique that is good, the better technique. less rigid, maybe it'll prolong the life of the fibers. So I would like to know from them.
Okay.
You know, this is definitely different than what we had before. Is this an improvement for us? Because it's blurring whenever we just push a little pressure on the stem.
Gotcha.
But you can see the actual movement we're getting here of the bones. We're starting to get some movement of the bones. His bones were not moving at all. And the laser is just brilliant at removing. Look at this thing. That herniation right there is just wonderful. So easy. It just peels the herniations right off the spinal cord, which is exactly what I want. And we're starting to get some movement of the bones like it's supposed to, right? The disc, a lot of people don't understand the disc is a joint. Joints are meant to move. And what happens is when you get an injury to a joint, like this patient's had an injury to these discs, the joints don't move like they are supposed to. So they lose movement. For many people that movement's painful. So they actually stop moving their neck or their back because it hurts. Okay? That painful movement stops people from moving their neck or back. Or if you have an injury to your knee joint, right, and the knee joint hurts, then you're going to stop moving your knee joint to stop the hurt. And, you know, it happens all the time. People say, oh yeah, I just take it easy. I don't really do much to compensate for that pain. Well, I don't believe people should restrict their lives. Okay? I know the insurance company wants you to do that because it's cheaper for them rather than paying for your back or neck to be fixed. They would rather you just be, you know, inactive. Because that doesn't cost them anything. Okay? But the reality is that I don't work for the insurance companies. I work for the patient. And the patient deserves to have an active life that's pain-free. And I can provide that to you, you know, for your back and neck, of course. I don't fix knees. But it many times requires treatments, right? Like this type of treatment you're seeing right now. So it's pretty good optics. Like the clarity is good.
Yeah.
But the only thing that concerns me is with a little bit of flexing, it deteriorates.
I can
Okay?
Yeah,
And just see if they have a better solution for that.
no problem.
So, yeah, fucking wolf.
We have another question.
Yep.
One of our viewers says, I have had 2 ACDFs, 1 PCDF, and also 1 TLIF that had to be corrected with new implants afterwards. I've had probably a total of 72 injections in my back, and nothing has ever worked to relieve me of pain. What are
Wow.
my next options?
So for the person who says I've had all that surgery on their back and fusions and injections, the best thing to do is, honest to God, come to Duke Spine Institute. You are never going to find a doctor elsewhere who can fix you. You obviously have very complex issues. And what I mean by that is simply that if you've had a fusion, then the bones that are fused, those discs, they're definitely not the cause of your pain, as long as the fusion took. Okay? So what's causing your pain is something next to where you were fused. It could be your sacroiliac joint. It could be your piriformis muscle. But it's going to require some serious diagnostic efforts for us to figure that out. And that's going to require some diagnostic blocks. And then once we know what the source is, whether it's your sacroiliac joint, your piriformis muscle, your ischial tuberosity, where your hamstring muscle attaches, whatever the cause is, we can fix it for you. But it's really about diagnosing properly, making the right diagnosis. That's your biggest issue right now. These are all fragments of disc herniation. So you have what's called a failure of diagnosis. Very common problem in the spine. Literally happens virtually everywhere, which is why we encourage people to get better educated themselves on the causes of back pain. By the way, that vein right there, that purpley vein, is right on top of the dura. That's the spinal cord, just for those of you who don't know. That's where we've decompressed the spinal cord right there, completely. Now I'm going to the other side. I'm going to do the same thing. These are bone spurs. I'm not going to take every bone spur out of here. There's a piece of herniation right there, floating it out. So what you need to do, whoever that is you need to come to Duke Spine. Plain and simple. We need to figure out what's wrong. There's definitely something wrong, and it can be fixed, most likely. I just need more information. I can't do it over the phone. I got to get more information. But you've got something going on wrong. I can promise you that, and it is fixable. It's probably a joint or a muscle near your fusion that your doctor is not able to fix for whatever reason, and that's a very common problem. You know, the back and the neck get complicated real quick for surgeons and doctors treating patients. So you need to have a multi-specialty approach to fixing it. Woo-wee. Yeah. I don't know if that answered your question, but yeah, I think one of the biggest misconceptions out there is that people think all spine surgeons are the same, that we all fix people the same and we're all equally good and we're all have equal complication rates and we all do the same surgery. You know, a fusion is a fusion, but it's absolutely the furthest thing from the truth. And I've talked on this before. Every single spine surgeon in the world does their fusions differently. Okay, 100% differently. I guarantee you I could watch 100 spine surgeons do a T-lift and I could see 100 different deviations in how they do it. Because there really exist. No two surgeons do the same surgery the same way. And I'm going to tell you right now, the devil's in the details with regard to results and complications and outcomes. The surgeon has to be doing things exactly right, to the millimeter or even half millimeter at times, in order to get the very best results. And it can be the difference between a pass and a fail, honestly, and it is. So we published our T-lift results years ago, and we had 85% relief of back pain and a 90% relief of leg symptoms. That was back in, I think, 2013 at Duke Spine Institute with the technique that I use. But the technique I've improved upon, it's gotten even better. And our results are now 95% relief of back pain and 95% relief of the leg symptoms. So we've gotten better results now than ever before. See why the blue is so important? That's a herniated disc right there. Okay? And my God, look at the movement we're getting now. Nothing like it was in the beginning. Okay. This patient, actually their back is bothering them more than their neck, but the reality is that their spinal cord is being pinched on and they're getting spinal cord damage. Basically going paralyzed. Huh? I couldn't hear you.
Did you say needs to be more paralyzed?
I don't know. No, I don't think the patient needs to be more chemically paralyzed. No.
Okay.
I was explaining to our viewers that
Complication.
this patient was going paralyzed from spinal stenosis. Their spinal cord's being pinched so bad that they were losing, their balance. And
Yeah, I was wondering why he said he was losing balance.
he was losing
That
balance.
is from
The spinal cord being pinched.
lack
The nursing homes in the United States are full of people like this guy
Mm-hmm.
that their doctors never diagnose spinal stenosis in their neck. And they end up basically, losing all control of their body, slowly going paralyzed. And they stick them in nursing homes because their families can't take care of them because they're too busy, They can't take them to the bathroom, they fall. They can't, take them to the kitchen, they fall. They can't do anything. Shower. So they need help with our activities of daily living. They need assistance because of their balance problems, their weakness in their legs, eventually numbness in their hands, completely preventable.
So now old age,
It's
what,
not from
what's
old
the
age.
age limit that you would operate?
What's the age limit that I would operate?
Yeah, elderly patients.
They have to be really, really, really old for me not to operate. As
90?
long as they're medically fit. No, I've operated on 95-year-olds. If you have a person who is 95 and they're healthy, they have a good heart, good lungs, they want to enjoy the last years of their life, and they're in pain, and the pain is keeping them from doing it, why would I deny somebody their right to getting rid of their pain with surgery when I can do it safely and effectively even at 95? Oh, look at that piece that came out. That's beautiful. All right, we're very close to being done.
We have one more, right?
Yeah, we have one more.
Now, what about the osteoporosis of the bones in patients like that?
So our anesthesiologist is asking, what about osteoporosis? How does that affect?
Yeah.
The reality is osteoporosis doesn't affect this surgery at all because,
Brittle bones or
no, brittle bone, we're not operating on the bone. We're operating on the disc, the joint between the bone.
you're hammering on the bone?
No, we're not hammering on
Oh,
bone.
you mean correct. I'm sorry.
That's okay.
You are hammering
I forgive
into
you.
Okay, hammering
We're hammering into the disc.
correct. Sorry.
Yeah. We're not hammering the bone at all. We are pushing the bones apart. That's what the hammer is doing.
Sorry.
It's not going in the bone. It's not doing anything other than pushing the bones apart.
Correct.
Wow, look at that. This is right on the nerve. That thing is pushing, that bone spur is digging in right there. So for those of you who wonder, can the laser get rid of bone spurs? I've been doing that this whole surgery. These things are bone spurs. These white things. Pretty cool, huh? Anyway, I'm just about done. I'm going to pull this back and redirect it. And that's looking good right there.
We have another question.
Yeah, sure.
One of our viewers is wondering, I was recommended
See what
a
I mean,
fusion
Luis?
surgery in my neck at C5-6, but instead
Uh-huh.
I've been doing shots and physical therapy. It's seeming to work to relieve my pain, but am I doing more harm than good by not going into surgery?
Well, we have a really good question from one of our audience. They're saying, I've been recommended for surgery to have a ACDF, which is an anterior cervical decompression infusion, and I've been doing shots instead, and am I doing more damage? The answer is quite likely yes, and I'm going to tell you why. Surgeons usually recommend ACDF surgery to unpinch a nerve. That means that you have a pinched nerve or a pinched spinal cord. And those are both not going to get better with shots. And the pinching is only going to get worse. Well, when you pinch your nerve or spinal cord, you do nerve damage and spinal cord damage over time. So I would be inclined to say, yes, you are going to get worse and that it's a bad idea to avoid surgery. However, by avoiding your ACDF, you learned about the Duke laser disc repair. So there is a silver lining to this story in that you don't need an ACDF. You come here and get this procedure done instead, and then you won't have to have a fusion at all. We just unpinch the nerve and spinal cord with the laser. And you won't be able to get that where you are because they don't do this surgery. It's too advanced. You're looking at the future of spine surgery, folks, right now. In the future, these surgery you're watching, the Duke laser disc repair, will replace ACDFs, and it will replace lumbar fusions, and it will replace laminectomies, microdiscectomies, pretty much every other spine surgery that's done for degenerative discs, herniated discs, spinal stenosis, radiculopathy, neurogenic claudication, all of those conditions, which is 95% of spine surgery, by the way, will all be replaced by this technology. It's just that I'm one of the first in the world to do it. And so eventually the other surgeons will be trained, but it will take a long time. And this surgery will disseminate around the world like all other technologies eventually do, and surgeons around the world will be doing it. Problem is, today in 2020, they're not. I'm the only one. So if you want this surgery, there's a herniation just came out of the foramen on the patient's right. If you want this surgery done in 2020, foreseeable future, you need to come here to Florida, bring your family, say hi to Mickey Mouse, Minnie Mouse, whichever is your favorite, Donald Duck, and get your neck or back fixed. Okay? We're done with that disc. So, if you've been following along, we just repaired a herniated disc with stenosis without doing a fusion. We did it through a 4mm incision. And this patient's going to go home from our center an hour after surgery. So this is not done in the hospital. You don't have to go to the hospital for neck and back surgery anymore, especially for endoscopic surgery, Duke laser disc repair. The hospital actually can't even do the surgery at the hospital because they don't have the equipment that's necessary. You understand? The hospital doesn't have this equipment we're using. They have a little bit of it, but they don't have the necessary things that we use to be able to do this surgery. They don't have the scopes, they don't have the retractors, they don't have most of the instruments. So where's our blood pressure? Good? Perfect. I love it. Let's get in for a lateral, please. So next step is going to be removing the tube. We call it the tubular retractor. It's basically, retractors are metal things that move tissues over so the surgeon can see what they're doing. And in this case, we're taking the tubular retractor out. Okay, huh? Let me have that medicine back again. I want to put some more.
No, I said he needs to probably pull the shoulders.
Yeah, we'll probably need a shoulder pull on the next one.
Okay.
Huh?
Oh, shoulder pull, you say?
Yeah, shoulder pull.
Okay.
So we can see the next disc.
No, but you're good.
Shot. I may need you to provide some inline traction. That's all.
Okay.
Take. All right, so we're done with this first level, and we're going to wait a minute. Shot. Is that our shot right there? Where are we at? Good. All right. So you can see 2, 3, 4, 5, 6. We're in the C5-6 disc. Everything went absolutely perfect. And now I bet you this patient's going to have more movement of their neck after the surgery. Maybe not immediately after, but eventually. Who is that?
I believe he's that's a new RN. That's a new RN? Yes. Alright, what's his name? What?
Hey, Ben.
Ben?
All right, so we always got to ask me for new people in the room, okay? Hey, Ben. Nice to meet you. Welcome aboard.
So, if we get some of that today, or we can go do other things.
Whatever he wants, whatever you want to do for him. It's just that I want to know who's in my room, because I don't want anybody coming near the sterile field that doesn't know what a sterile field is. So I know he's nowhere near it, but that's good, but I don't want them accidentally touching something they shouldn't be touching. So we have to keep an eye on newcomers. All right, so at this point, we've done the disc repair at C5-6. We've gotten all the pressure off the nerves and spinal cord. Next is C6-7. We're going to need to pull on the arms and try to pull the shoulders south a little bit. I would say, yeah, I'm talking out loud. I'm just thinking out loud first before we do it. I'm just thinking we probably should bring the fluoro a little bit further south, like probably an inch. So let's start with that. And then when I'm ready to start moving this dilator, I'm going to have you pull on the arms down there. And maybe you can give me some inline traction on the head and neck.
Okay.
That will keep the body, to keep the head from moving south.
Okay.
And then Luis and I may end up pulling a shoulder, or at least Luis will pull the shoulders up here.
Okay.
And then that should open up our view. You can see the collarbone is right there at the C6-7 level. I still feel like we can get it.
Okay.
I'm going to need Jordan to move relatively quickly between lateral and AP. So just be ready on your toes when we're ready to go.
Okay. You happy with the relaxation?
Yeah, relaxation's good, blood pressure's good. I wouldn't let it go up any higher.
Okay.
So you tell me when you're ready, Dr. Kalkarni.
I'm doing inline
Nice, I
flexion.
could feel it. My God, it took the pressure off my dilator. Shot? Oh yeah, that's nice. So everybody go ahead and do your thing, and I'm going to try to come out of the disc space and get to the next one safely. Shot, so I'm pretty close to being out. Yep. Over the lip, there it is. Now I'm on the front of the bone. Shot. I'm going to move south, but I need an AP view. AP, Coker. Luis, you relax. Everybody else stay where you are. Do not take the shot yet. You're far too close to my hand.
My traction will
Your traction's fine.
continue.
Yep.
Okay.
Shot. All right, you got to get that lined up. That's really nice, actually. Go back to a lateral. Take that. Everyone do your thing. You're doing good. Luis, go ahead and slowly get in there. No sudden movements. Give me a lateral view when you get it. Okay, moving south. Shot. Over it. Shot. Perfect. Give me an AP view. Coker. Now, quickly. Perfect lateral. Take. My blood pressure crept up a little bit. Just everybody stay where you are. Shot. We're almost done. Perfect. Give me a mallet. I want to anchor the tip. Shot. AP now. Coker. All right, that's looking good, really good. Back to a lateral view, please. Almost done. Shot. Good. Not ready yet. Let's see what we got. That's good. That's good. All right. Let's get an AP again just to make sure, and then I'll let you relax. Both of you, are you still pulling the arms? Yes. All right, good. Stay where you are. I've just got to angle this down a little bit, and we'll be fine. All right. I need a true AP. I don't think we're far off, but all right, that's good. Good, 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 good. Perfect. Lateral. Just stay where you are while I reposition this, and we'll be done with the neutral inline traction. Shot. Shot. Hey. All right, you can relax.
Relax. Oh my God.
Shot.
Relax.
All right. Pipe cleaner. Shot. Shot. Take this. It's the hardest part of the surgery, by the way. You guys hear me okay? Shot. That should have given us some dye. All right, then let's get an AP. Looks good. Lateral. All right. I need to advance this further. So, are we nice and relaxed? Shot. Shot. Let's give a shoulder pull.
Shoulder pull and inline too.
Sure.
Okay.
Let's just see where we are in the lateral view. Shot. Yeah, I like it. A little bit rotated, but we're good. Let's try this. This is the hardest level to do in the neck, besides C2-3, which we never do that, because nobody ever has 2-3 disc herniations. It's just the biomechanics of the spine, the way it's angled, etc. Most disc herniations occur at 5-6 that are symptomatic, and then 6-7 shot. So C5-6, C6-7 are the two most common.
Can I relax?
Yeah,
Thank you.
but we're going to be coming back, so I'll need you again.
96 over 58.
Yeah, I'll need you again in a second,
Okay.
whenever you're ready.
Okay.
Shot.
How was that?
Beautiful. He's still relaxed, right?
Correct.
Yeah. I just want to keep him relaxed a little bit longer.
No problem.
Shot. We're almost done. He's a little bit tight here, but he has no twitches.
No twitches.
Shot.
Another thing is he's cold.
You can warm him up.
I know. I'm using everything. Can I go up on the room temperature?
Sure. Yeah, we can go up on the room temperature. If you want to go up on the room temperature,
Yeah, I do.
no problem. Go ahead.
Thank you.
Safety of the patient always first.
And then
Shot.
he'll recover better.
I think we're good, Dr. K. You can
Thank
remove.
you.
Just make sure he's relaxed. I don't want his paraspinous muscles clamping down on me right now.
Now, I think he is. You tell me. I just hate to have to give. Let me check.
I mean, his neck is getting tighter, so it's not a hematoma, but it's just I feel the muscles are maybe a little bit.
I can give him
A little bit.
touch more. How about that?
Yeah. Will you check his switches?
I did just now, and no switches.
0?
0.
Yeah, I would just do a touch more then,
Okay, no problem.
because we know that the 0 is not really
Correct.
0 usually.
And on 4
Yeah, stuck again. Actually, yeah, I may need some, let's see. If you can give me some inline traction for a second, that would be great.
Just give me.
Oh, never mind. We got it. We got it. All right, let's get the fluoro out. All right, do we have any questions? We are getting ready to start the second of the 2 discs. And this patient, just so you all know, doesn't have any complaints of neck pain. We're not doing the surgery for neck pain. We're doing it because his spinal cord and nerves are being pinched and he's losing balance. So losing function, neurological function. So that's a very good reason to do surgery. I got a question earlier from somebody saying, I'm getting shots, I'm feeling better. Do I really need the surgery that my surgeon recommended? My answer right off the bat would be yes, you do. You know, I don't think the surgeon's necessarily doing your surgery for pain. We do a fair amount of surgery for pain, but we also do surgery for neurological dysfunction, basically compressed nerves and spinal cord that need to be unpinched. So that's really what we're doing here today with this patient, for example. So this is a good example of where you do need surgery because your surgeon tells you to get it done, and you need it not for pain, but for basically so you don't go paralyzed. So anyway, those are all herniations right there. I'm floating them out. The blue dye stains the nucleus pulposus. The nucleus pulposus is the herniation. And as a matter of fact, just looking at those pieces of disc herniation, they look younger than the ones I took out earlier. So what that means is that this disc herniation probably is more recent than the last one. The last one looks like it's been going on for 20 years based on the amount of scar tissue. This one here looks newer to me, you know, endoscopically. And I can see all these details other people can't see because I'm inside the disc right now, and not just inside the disc, I'm inside the herniation. Look at that piece right there. Still scarred up pretty good. Definitely not recent as in the last year. Definitely herniation here that probably happened, if I had to guess, at least 5 years ago. Maybe longer.
Can I ask you a question?
Yeah.
Now, he said he fell about a month ago.
Uh-huh.
Do you think that may have been from imbalance?
Of course he fell from imbalance.
Okay.
That's the whole point.
That's how they, CT when you did, someone did.
Yeah, people fall because they lose their balance. Now, some people just trip and fall, or they get drunk and they fall. But when they're not drunk and they're not tripping on a carpet, their legs aren't working right.
Correct, myopathy.
That's myelopathy. And
Now,
that's what
he
we're
had a
working on.
subdural, he said. When it
Uh-huh.
was small,
Yep.
he had a subdural hematoma.
Yep.
Having been on Xarelto.
Yeah.
He said you looked at CT.
Yes.
Where was it?
He had a subdural that was tiny,
Okay.
and he had a repeat CT that showed that it resolved. But honest to God, I don't think he even had the original subdural. I think the radiologist overread it.
Okay.
But, you know, in reality, you don't know. Because what happens is the way they slice the scan through your head is that they can sometimes get the skull tangentially, and it looks like a subdural, but it's not really a subdural. It could be some calcification of the falx. How's our irrigation? Seems like weren't having as much as we needed there for a second. All right. Do we have a question?
None right now.
All right. So I'm working between the bones where the disc is, and I'm zapping away disc herniation.
10, 15 minutes heads up, doctor.
Yeah, we need about 10 minutes.
Oh, okay.
So maybe less.
Oh, okay.
Yeah, when I always get to the last disc, it's always 15 minutes.
Okay.
You can anticipate we're going to be done.
Okay.
So I know you're very astute.
Thank you.
You've been paying attention, and we have 2 discs to fix, and
Because
we've already
he
fixed one.
He gave me very little time.
What?
Explanation.
Good. Then Luis
The
is
only thing is,
Luis is doing his job.
being cold, sometimes I need time.
Well then warm the room up.
Yes, I did. He is working on it. Oh, it's not. Now, I need some Demerol, please, in case if he shivers. Okay.
Demerol. Do we even carry Demerol?
We do. I
Ah.
just found out this morning.
Ah.
Do you have it or do you need it? No, you have quite a bit of good stuff.
We have quite a bit of good stuff. It's good to hear.
Necessary, important stuff.
Yeah, well, I always want my center to have the very best of the best.
Thank you.
Everything that we need for the patient's comfort and safety. And of course, then there's my comfort and safety,
Correct?
right?
Correct?
Making sure that the room is not
Now,
too
I was
warm.
going to, make a comment and see what you think.
Oh boy, here it comes.
Now, when there are 3 cases, I can start
Uh-huh.
7:15 in the room, so
Uh-huh.
I get done. But if you get me out by like 5:50,
Yeah.
then I can drive in a reasonable amount of
Yeah, yeah. But the problem is I may
I
not be
wanna
able to
make
be here at 7 o'clock in the
Well,
morning.
and do the easiest of the easiest late, like carpal tunnel.
Oh yeah,
You
of course.
can do as a third.
That's what it's supposed to be.
Then I can get 3 cases done for you.
Yeah, I mean, the way it works is I always tell the staff, post the hardest case,
First.
the biggest case first, because it requires the longest recovery, right? So these are fusion, lumbar fusions, or posterior cervical fusion, or ACDF,
Correct.
and then,
So I can do as
Um,
many cases as you want. If I can start early, if all staff is in agreement,
uh,
and I can do very quick turnovers as long as I get coffee. And if I get out by 5:30, then I, like from here,
yeah.
that's my request.
Well, I have a request too,
What is it?
that I'm not going to be here at 7.
Well, then what do
So,
you do?
I don't know. That's not an option. That would be like saying, can you operate naked?
Then you'll have
And
to
I
pay
would
me
say,
more.
no, I can't
Then
do
you'll
that.
have to pay me more.
Yeah, you're right. That may be the answer.
Okay, I take it.
No way. You're so funny. What you don't understand is that if I have to pay you more, you become down on the totem pole for who I hire.
Well, then go for it. Go for it. I know you're not going to get someone like me.
You're right. There's nobody else like you.
I'm special.
That is true. I agree. You are special.
I've been told many times. It's like, okay, I'm not here to suck up to people. I'm a good person.
Yeah.
But if I have to stand up for the patient, believe me, I will.
Oh, I know. Me too. I'm the same
Yeah,
way.
see, that's why I like you.
Yeah. That's why I like you.
So you have to come to a compromise and see what you can do. Either come in early.
I can't come in early.
Well, then you got to pay me a little bit more later for 3 cases.
I understand.
The chances of that are small, right? 3 cases?
3? No, we get 3 quite often.
No,
Lauren says so, at least.
then you have to be kind to me.
I am kind to you.
Getting me out by 5:30.
But what do you mean getting you out? You make it sound like you don't want to be here.
No, I have to drive back, right?
I mean, this is such an awesome place to work. Why would you not want to be here?
No, I want to be
You
there.
should be paying me to come here.
Sure. So I get home in a reasonable amount of time.
Buy a house in Brevard, not Brevard.
All right. We've done everything we can at that disc.
You done? Perfect.
Yep.
Lights on, please. Lights on.
What time do you get up?
Oh, well, what you really should be asking, what time do I go to bed?
Well, man,
What do you think I do when I leave this place? You think I...
rest.
No. Nope. I go to sleep at 2 o'clock to 3 o'clock in the morning every night.
That's not good for you.
I have 5 businesses that I run.
Now,
I have a coral farm and a lab where I do research. Those I cannot ignore.
a cow farm?
Coral farm. I grow coral. I research coral. I do research on coral growth, coral health, coral diseases. I'm trying to save the reefs from dying. You didn't know that?
No, I didn't.
Yeah. There's nobody else that's going to save them. Nobody.
How did you get interested in that?
I got interested because I love nature. And there's a beautiful world underwater. You asked me a question. Are you listening?
I am actually.
Okay.
Go ahead. Coral.
No, I said that you asked how I got interested, and I said I love nature, and there's a whole world underwater that people don't know about, and that's where the coral and the fish are. And unfortunately, it has a profound impact on what happens to the rest of the world. So if the coral reefs are not saved, the rest of the world will die. And people don't understand that.
Correct.
And frankly, I love my children so much that I want them to have a world that they enjoy living in. Did you ever see The Matrix? No? You should go watch The Matrix. Huh? It's a movie. It's a movie. Fictional movie.
Fictional movie.
Yeah, but fictional movies have basis in reality,
I like romantic movies.
of course, because you
Now,
live in a
must be-
fantasy
you
world.
must be so sad about the Australian
I'm
ferret.
sad about all the reefs, the Indonesian reefs,
Now,
the Indo-Pacific, Australia, Caribbean,
Cozumel,
all that's the Caribbean. All the three major reefs, all the reefs in the world are dying. So I'm trying to save them in my
so
as my job number 2 after
how are
neurosurgery.
you doing that?
Well, the first thing you have to understand is why are they dying? And the world doesn't understand the truth. They don't know the truth. The truth is there's a parasite killing them, killing the coral. And I've discovered the parasite, and I've published it online. The problem is none of the marine biologists who control the funds and organizations, they don't know about it.
So what kind of parasites?
It's an enteric parasite. It lives in the gut of the coral, which is why nobody's discovered it until I found it.
It has a gut?
Yes, corals have a gut. See, a lot of people don't know that. They're an animal. They have an intestinal system where they digest food, and this parasite lives inside, not on the surface, but
Like
deep
E.
inside.
coli?
It is just like a worm, like filariasis or some type of a parasite that lives inside its host, and it eats the coral from the inside out, eating its cells to get to the zooxanthella, which are the algae.
Oh my God.
And nobody understood this, or nobody realized this parasite is killing the coral. But I did. I
See,
discovered
you
it.
know, you would think corals, yes, scientifically they're alive. I mean, they're living organisms.
Mm-hmm.
But when you look at
EBL 10 mil?
okay, times 2.
No, real 10 mil. I don't do times 2.
10 base.
Why is his skin red? Why is his skin red? We gave him clindamycin, right?
Clindamycin, correct, yeah.
Is he allergic to iodine or anything?
No, no. You, he's
Penicillin.
bleeding?
No, he's not bleeding. His neck is supple. Everything is fine. His neck is red. The skin is red. You see it? But we didn't give vancomycin or anything. I mean, he may be having an allergic reaction to a medication, right?
Possible, but hemodynamic.
I don't see any welts. I don't see a macular papular. Wait, something here.
Well, he is
That's just a seborrheic keratosis.
he takes turmeric. Now, it's ideal to have patients stop turmeric.
Oh, he stopped.
2 weeks, but he only stopped Thursday.
Last dose was 120.
Last
Yeah,
one?
so he stopped a week ago.
I know, that's not ideal. The last Thursday. 5 days.
All right, so we're going to go ahead and close this up. Just so you all can see, the incision is 4 millimeters. It's tiny. We're going to put the steri strips on and then a sterile bandage. Before you get the tube out, let's examine his body. If you think he's having, is his airway pressures are good? They're not having any bronchospasm?
No bronchospasm, all good questions. I can raise his head up. Now,
He's perfusing. Maybe it's just a perfusion. Maybe this is his color. He's just perfusing.
sometimes the pressure can do that.
Uh-huh.
Maybe he's cold.
Did you give him anything for blood pressure? Hydralazine?
No. I just go up and down on the anesthetic.
Is his skin really cold?
Yeah. His skin's not cold, it's warm now.
Let's undo the, I'm okay. I don't.
It could just be he's a redneck, right?
That's what I was going to say, but I did not.
After all, he is a redneck.
I did not want to make politically.
It's not political. This is people in the South are rednecks for the most part.
No, but why were they called? Because they were farmers.
Yeah, because they were out working in the fields. The sun was burning their neck. They were salt of the earth people, or salt of the earth people. Huh?
Redneck ladies.
Redneck ladies. They're definitely redneck ladies too.
Oh, do you know that in Lake City they're called bubbas?
Bubbas? Really? Rednecks are called Bubbas in Lake City? Interesting.
Lake City area.
Well, there you go, folks. You're getting a little bit of Florida historical, cultural information. But the surgery went well. I'm pleased. And I'll come answer some questions. So start typing your questions. Our next one is a 2-level or what?
He's actually
4.
Bilateral, one side and one
Because
side.
he's
So it's
very cold.
4 level.
Otherwise, he's not gonna wake up.
Okay.
Can Ben come in? I apologize for that.
Yeah, that's fine.
The
The next,
surgery and
the next surgery is going to be a 4 level, but basically 4 areas. Duke laser disc repair, lumbar. I think it's probably the color of his skin. I know he has a reddish skin. I just want to make sure.
his face looks fine.
Yep. It's better that we just check and make sure.
Oh, it's nothing to do with anesthesia, doctor.
No, I know that. It could be medication.
I'm just admitting, I'm just saying, so, everybody blames anesthesiologists. That's why you're ready for that?
Yeah, of course we do.
Sure.
That's why you're here.
It's important to know
You
where
know,
place
I
blame.
didn't used to have thick skin.
Yeah, he's fine. Like,
Yeah, it's fine.
maybe he just like he gets red, he gets red.
Yeah. Yeah, I just want to make sure.
Need an upper body bare mother, please.
Okay.
All right, so we're all done. I'm going to come over and answer some questions for y'all.
So now,
So start typing them up.
my concern, you like to have esophageal steps over it. Is that going to work for cases like this? So I think
All right, thank you everyone for joining us for the post-op Q&A. We have Dr. Duke in the room with us right now. And we have a viewer who submitted another question over the Duke Spine Institute app, which can be downloaded on either iOS or Android to submit questions during the surgeries. The question asked was, my spine surgeon told me that it may take up to a year to regain function in my legs after I have the nerve root in my lower back decompressed. Is that true? And this question has come from our app, which can be downloaded on iOS and Android, but you can also ask these questions on our Facebook page during the surgery or on Periscope, Twitter, and YouTube. We stream across multiple platforms to allow you to engage in the audience in any way you'd prefer. And here comes Dr. Duke with the answer to the question.
Well, good morning, everyone. Hopefully everyone's doing good. Shout out to my friend out in Australia who's going to be coming and visiting us soon. So this person's saying, I had back surgery. My surgeon says it can take a year to regain function in my legs after I have my nerve root unpinched, decompressed or unpinched. Is it true? The answer is yes, it is true. So patients that have pinched nerves in their spine, whether it's in their neck, and the nerve goes down their arm, or it's in their lower back and the nerve goes down your leg. When those nerves are pinched hard enough or long enough, you can actually start to get weakness in your leg or arm, numbness, where you can't feel the skin that well in your leg or arm. And you can even get, obviously, pain shooting down your arm or leg. And you can get tingling feelings like pins and needles working their way down your arm or leg. Those are the 4 sensations that people get when they have a pinched nerve. Now, they don't have to have all 4. You may have just one of those 4. But with weakness and numbness, if you've had your nerve unpinched and you had weakness or numbness in your leg or your arm, if it's in your neck, for example, and you have a herniation in your neck pinching the nerve. So if you had weakness and numbness before surgery, and the surgeon unpinches that nerve, you can have weakness and numbness for up to a year afterwards. Now, if it goes longer than a year, it may not come back. But here's my advice to anyone with this scenario. Numbness in particular takes, usually when I do surgery, if someone's got bad numbness, it'll take 3 to 6 months for things to come back to normal. But here's the problem. I can't vouch that your surgeon decompressed your nerve root properly, because what I found in my career is that a lot of patients that had unpinched nerves by other surgeons really didn't have their nerves unpinched. The surgeon probably went in with good intentions but just never got the job done. It happens quite often. I would say at least 60 to 80% of patients that get their nerve unpinched don't really get their nerve unpinched. You wouldn't believe the kind of stories I've seen. I've seen surgeons say that they did laminectomies when no laminectomy was ever done. They put it in their operative report. Why? Because you get paid based on what your operative report says. And if you don't say you did laminectomy, then you're not going to get paid. So a lot of surgeons, unfortunately, are not well trained. They're not comfortable doing the surgery, but they have to graduate come graduation day, 7 years or later. And they end up being released onto the world, and their skills are just not really good at all. You might as well have your janitor do your neck surgery or your back surgery for some cases, because the surgeons are so bad. Unfortunately, these surgeons come to light sooner or later, and the world finds out that what they're doing is, horrible surgeries, and people are dying and being paralyzed and all this stuff. So I'm not saying your surgeon's a bad surgeon. I'm saying that I have no idea whether your surgeon did the job right or not. If you're still having symptoms in your leg after a decompressive surgery and you're not sure that the surgeon did the job right, I think you have to have a candid discussion with the surgeon. For me, I actually can see the herniation with the scope. I can see it directly. I know 100% I've gotten rid of the herniation, because at the end of the surgery, there's a hole in the disc and the annulus right where the herniation used to be. And I can see the bones, I can see the disc, I can see the outer margin of the disc, I know exactly where the herniation was in the foramen, and now it's gone. I can see all that. And I can see the nerve. So with the Duke laser disc repair endoscopic surgery, you can actually see it too, because you get a copy of your surgery when you leave the surgery center. Plus it's being streamed live around the world, so everyone in the world can see, if they want to, the work that I've done. So there's absolutely no question in your mind or mine that the decompression was done. Okay? With all these other surgeons, you have no idea what they really did in the operating room. And I'm not trying to instill fear and paranoia. I'm not a fear mongerer. I'm just a truth mongerer. Okay? So I want everyone to know the absolute truth. And whether you come and have me operate on you or not, frankly, I don't care. Of course, I'd like to help as many people as want help, but I'm not here to fight with you over it. And if you want to live in pain and you want to do something else, by all means, feel free to do it. My belief is that a good doctor makes the right diagnosis for the patient and educates the patient about what the problem is and what could be done to fix it, and that a good doctor keeps up to date on the best treatments in the world for that condition that they're treating, and that the good doctor can perform those treatments perfectly to the best of their ability, but not just their ability, to the best that can be done. So aside from that, like convincing people that they need to have their spine operated on, that they're going to go paralyzed otherwise, that's up to the individual. If I've done my job, I'm perfectly happy. Whether you get it done or not, that's up to you. I'm not saying that in a mean way. I'm just saying I'm not here to fight with babies and get them to drink their milk. If people are grown adults, they understand the problem, they understand the right way to treat it. If they choose not to treat it, that's their choice. So I still remember in residency as a neurosurgeon, which I am a neurosurgeon, we had a patient come into the emergency room at Shands Hospital in Gainesville when I was a resident neurosurgeon. And when I heard that this patient was coming to the emergency room doctors called me and said, "You're not going to believe this. Get down to the ER, and you may want to take an antiemetic." So when an antiemetic is a medicine that we take to stop vomiting. And I'm like, I've got a cast iron stomach. There's nothing down there that's going to make me want to vomit. When I got down to the emergency room, there was a man sitting on a gurney, and he was awake, and he was talking. But I noticed something right away. He was missing half of his head. And when I got closer, I saw all this raised skin and tissue around his head. And I realized the guy had had skin cancer. And skin cancer that he'd had for probably 10 to 15 years, but he never treated it. Never treated it, not once. And the skin cancer ate through his skull into his brain, and his brain was exposed about the size of a tea plate, you know, where you put your teacup on. And you could see his brain. And what was worse was you could see the maggots wiggling around in his brain. And of course I asked him, I know this didn't happen overnight. Why didn't you get this fixed? And his response was quite interesting. He said, if God wanted it fixed, God would fix it for himself. I said, what do you mean? He said, if God wants me to have something done, God would have done it himself, because God is all powerful. And I'm like, yeah, that's true, but that's why God put surgeons on the earth to help people like you. So maggots and all came out eventually with brain surgery that we did, and that poor man ended up spending 6 months in the hospital. My point here is that you can lead a horse to water, but you can't make him drink, okay? So I'm not here to convince people to come and see me. I'm here to tell you the truth. You've got to figure it out. You've got to understand what's going on with you. And then if you want to fix it, get it fixed. But I can tell you this. I know that probably 60 to 80% of decompressions on people around the world are not done properly. And those patients continue to have pressure on the nerve even after their surgery. The surgeon won't admit it. They'll never tell you that. But if you're standing up and moving around and you feel symptoms shooting down your leg with movement, then you've got a problem that's ongoing. It needs to be fixed. The fact that you're moving around and it's making it worse means there's still pressure on the nerve, and it's changing with your position. Because disc herniation, stenosis, narrowing, where the nerves exit the spine, it's called the neuroforamen. It's a dynamic area. It opens and closes with movement. When you sit down and you lean forward, it opens. But the herniation pushes back further. But the foramen opens because the facet joints slide and open. When you lean back, the facet joints collapse, the foramen collapses. So, movement-related symptoms in the arm or leg is a clear indication that the nerve is still being pinched. That would be what I would tell you. So if you still have symptoms that change throughout the morning or afternoon or day with activities and movement, then you need something else done because the nerve is still being pinched. You're in that 60 to 80% of patients that have spine surgery to unpinch a nerve where the nerve is still being pinched after the surgery because the surgeon didn't do their job right. Okay? That's the reality of your situation. On the other hand, if you have numbness in your leg and it doesn't change throughout the day, it doesn't change day to day, it just stays numb, then either you had it before, you didn't know it, and the numbness will get better because the surgeon unpinched the nerve, or the surgeon did nerve damage during the surgery and you have numbness you didn't have before. So there's always possibilities. My advice to you is come see me at Duke Spine Institute or send me your MRI that you get now after your surgery. Send it to me. I'll review it and we can do a Skype and I can make a diagnosis. Is that the last question? That's our last question. I hope you enjoyed the surgery. If you haven't downloaded the Duke Spine Institute app, we have it for the iPhone as well as the Android platform. So if you have apps on your computer or phone, go download Duke Spine Institute app. It's free and it's full of really useful information I think you'll enjoy. Also, the Facebook group we have is called the Spine Surgery Support Group. I haven't turned a single person away yet, and it's a great place for people to come in and ask questions, get advice. We're doing a live stream. I'm answering your questions during surgery, but surgery is only 1 or 2 days a week. So if you have questions on other days, go to the Facebook Spine Surgery Support Group and ask to join the group and post your question. Other than that, we'll see you in about 45 minutes for the next surgery. Go grab some popcorn and a nice cold soda.